restroom through the hallway and to the left. There's restrooms there. And also there's a nice filtered water machine back there if you want a little water or something like that.
Decent crowd. Nice.
A lot of shoulder problems.
A lot of shoulder problems, and I'd be amazed how many in this room have both shoulders.
Yeah.
No problem, right? So you guys have some paperwork there that you're holding on to. The worksheet we're going to go over. Don't feel like you have to have that filled out. There is a checkout form in the back that we'll have some time to go over, which gives us some valuable feedback about, these workshops. And I hope to answer a lot of your questions before you leave today. One more minute, just in case somebody got stuck in rain. And with our, just trying to be mindful of everybody's distance and space, we tried to space the chairs out as best we could to keep y'all distant. We'll try to keep our 6-foot distance from you guys up here so we can take our masks off, because it muffles the sound so that you can not have to read our lips if you can't hear us, right? I think we're good. Yeah. All right, so I'll take this off. A lot of you guys have seen my face already. I'm Michelle Sierra. And thank you guys for coming and spending an hour with us tonight. We're going to do our best to give you a lot of helpful information, answer a lot of your questions. We'll stick around at the end for some question and answer time if we don't get to your individual questions. This is my husband, Steven Sierra. So not too often that we get to do workshops together, but it's nice when we do. We've been practicing together for over 20 years. Dynamic physical therapy has been in existence for 21 years this year. And so it's a pleasure to be here with you guys and putting this on together for the both of you. We do also have in the back Ryan Spano, who is one of our doctorate in physical therapists, and Lauren, who's our handy physical therapist assistant. They're out there at the Slidell location, also shoulder experts, and are going to be on hand to answer any of your questions as they come about towards the end. Okay, and they're going to be having their first workshop in Slidell the end of this month. We've opened it up to Slidell, and then our West Bank location will be having their first workshop this month. We've done this since June, maybe of last year, and we've had a huge success. Patients coming in and just learning a little bit more about what is the rotator cuff, how do these problems relate to me or other problems, and how does PT even help with that? Answer some of your questions. So first thing we'd like to do, since you know a little bit about us, is get to know a little bit more about you guys. So I'll have Steve call on you guys, a few of you ask first name, which shoulder you're having some problems with, and kind of what aggravates, and I'll take notes so it comes around later in the discussion.
Hi, thank you all for coming and giving us some time to share even with you regarding shoulders. From a treatment clinical perspective, we see a lot of variety in terms of limitations with shoulders. Things like reaching to your back seat, fastening your bras, putting on belts and those sorts of things. So it's interesting just to get some feedback, and hopefully you guys are willing to share some of your personal concerns, issues with your shoulders. I want to know a little bit more about your shoulders and what's going on with you guys. So would anybody be willing to share a little bit about their own shoulder? Yes?
Yeah,
Tell
my
me.
name is BJ.
Yeah.
Bert do I go by BJ.
Okay.
Sharon's the last name. I've been fighting shoulders, I don't know how long, 25, 30 years. Finally went to see about 11, 12 years ago. And ended up seeing Dr. Sawa. I didn't get the surgery, but he wanted to, but it's both of them. Both the rotator cuffs are torn, partial tears. I don't remember all of it. It's been so long since I had any pictures. And I've gotten it down to where I haven't even seen him in a couple of years because I'm seeing one of his assistants.
Right.
Who just gives me the injections and asks. And the injections just don't seem to be lasting as long anymore. That's why I'm here.
Yeah.
And I've got other back problems and so forth, and it's like one thing aggravates the other. Neck, upper back, lower back, hips, knees.
It's interesting because part of your reports are similar to what we hear all the time, and it seems like one thing leads to the next, and where do I start? If I get started with surgery, where does it end? Or I've started with some of the injections, some of that stuff, and the effectiveness changes over time. So thanks for sharing both shoulders with you, DJ.
Yes, sir.
What would you say your pain level is?
Ma'am?
Pain level on 0 to 10, if 0 is none, 10 is excruciating on average, or,
You know, it goes anywhere from 3 to 9.
okay. And what typically provokes that 9? What's the worst stuff that sets it off?
Standing too long, and
Now, standing too long will aggravate those shoulders.
it does if I'm doing things while I'm standing. You know, I don't do a lot of physical anything anymore. But I do measure houses, and some of that gets to me sometimes.
Working tape measures and having to,
Yeah, and just sometimes getting around houses, getting up and down the steps, grabbing on the post and stuff like that.
okay. All right, well, while Steve is working on the chairs, who would like to go next? And yes, ma'am. What's your name?
I'm Linda,
Linda, nice to meet you.
and I have a torn rotator cuff and a torn bicep, and I had surgery in my right shoulder because I had fallen and broken a bone. And they found out that I'm allergic to narcotics, so surgery is completely out.
Right. Miss Linda, what side?
Right side, I'm
Right
sorry.
Right side,
That's okay, yeah.
and pain level when it's
Pain
at its
level
worst?
varies from like a 3 to a 10. And I just started playing my clarinet again, and I have to use a neck strap because I can't reach out and I can't raise my arm.
Yeah,
while
I see your function. I
Yeah.
see that it's such a,
Yeah.
it's a visual, and it's what we
Yeah.
do, so you can kind of, it's easy to
And I mean, I
recognize.
came here and y'all helped me tremendously, you really did, and
Yeah.
I just, with falling and breaking the bone and having to have surgery, I just had to kind of get away from it for a little while.
Yeah, yeah.
Well, thanks for that feedback. I didn't know we had past patients in the audience.
Oh,
Sometimes
yes.
Sherry will let me know.
And they were, and y'all were wonderful, I had Don.
Thanks.
And he was excellent.
Appreciate
Really
that
excellent.
positive feedback.
Okay.
Anyone else?
I'm also,
Linda? Okay.
my right shoulder, I've had a car accident and tore 2 of the bands like 6 years ago.
Right.
But I also have a morphine pump in me for back damage from like 20 years ago. And I've seen people get these shoulder surgeries, and I think the surgery's worse than the everyday pain. So I want to do something besides
Yeah,
surgery.
yeah, yeah.
And what's your pain level typically?
It stays around a 4 or 5 unless I try to like stroke the lawnmower, then I want to.
Yeah.
You still got to do what you got to do.
Pulling,
Yeah.
Oh, yeah.
that forceful or
The worst is taking blouses off over the head.
dressing,
Mhm.
yes.
Yeah.
All right.
Anybody else with similar or different, maybe different ideas, different things that they're feeling?
Well, I have a right shoulder problem, becoming a left shoulder problem. A little bit of pain here, a lot of pain here, but I take ibuprofen, according to the directions, and I try to stay ahead of a majority of the pain because it's so great. I do a lot of things, I sew or cut fabric, I play the piano, I need my function, I want my function. And I don't know what I've done to get this, but I've got a tear, in one area, and also, there's osteophyte formation that's aggravating that area. So, my doctor's appointment with orthopod is tomorrow, y'all gotta heal me before then.
Let me see if my
Well, that's a
magic
mighty
wands
tall
are under
order.
somewhere. I got-
Lay hands and pray or something, we gotta get this thing done.
Yes, ma'am.
So, it's, you know, just, amazing how I'm falling apart at such an early age.
Yeah.
And what was your name?
Ruth.
Ruth, all right.
And Ms. Ruth, it's really common. I would say probably about at least 40 or 50% of the shoulder patients that I see struggle with both shoulder problems. And we'll get to that in part of our talk, but it's very common.
And your pain level on average when it's at its worst?
Without ibuprofen, about a 7.
Yeah, and any one particular activity that bothers it most?
All of them, back, forward, up, you
Just
know.
moving.
I do bands like this, somebody said maybe that'll help, so I've been trying to pump that out every day, and, like this, and then like this, and,
Yeah.
yeah, that's,
So,
you know.
so let me ask you a question with that. You've tried a few different little things. Has much of that helped you at all?
I think it has helped me, but I don't have, a standard of help, like, you know, now I feel better since I started that, I don't have that kind of thing.
Sure.
I think I heard it when I do exercises, my own home exercises every morning, and I used to do lifts with first 1 pound, whoops, 1 pound weights up like this,
Right.
and then 2 pounds, and then 3 pounds.
Yeah,
I worked up to that point,
sure.
and I think that is when I damaged, because I was lifting in the wrong direction or incorrectly, you know.
Well, thanks for sharing that with us, and I'll tell you, has anybody else tried to use Google as a therapist at all yet? You know,
Okay.
and I hear, it's okay if you have, because ultimately, you know, a lot of us innately, have a mentality that we try to help ourselves any way we can. It's easy to get desperate, not want to take pain meds and the such. So, but it's interesting, and we'll talk about that a bit more with the attempts at exercise and the attempts at helping yourself, how difficult it can be. And I've got a good story with Ryan in the room. We'll talk a little bit about that, about my personal story. So it's neat that he's here with us, and maybe he'll agree. Sometimes we disagree a lot, so but I'm perfect. But I'm usually right, just yeah.
With the rotator cuff. So we'll get started on your handouts now. If you have your pen and your worksheet handy, Steve's going to start helping you fill in some of those blanks.
So let's start with a little bit of anatomy, and we're not going really too in depth into this, but just some basics, because really it's got to start with an understanding of what is the shoulder, but more importantly, what is the rotator cuff. So, and I've heard it called many different things. So if you're in that category, I've called the rotatory or the rotator cuff and all these other things. And ultimately, though, doesn't matter what we call it. It's really just a group of muscles of 4. So one of the first one under the first question is it's a group of 4 muscles and joints that move. Move is the next word. The shoulder. Yep. So in essence, if you'll have that first 2 questions answered, this is view of the shoulder blade, a diagram of the shoulder blade. This would be the right side. The shoulder blade just sits over the rib cage, and it's made up of 4 muscles. You have 2 at the back side that you could actually poke on and feel. They're kind of deep under some more superficial muscles, and then you've got some muscles that are in between the bony scapula and the rib cage. And it's just 4 muscles that again serve to move the shoulder.
Oh, it's
Okay.
thought it was a bone.
What's that? I thought it was
I
a
thought it
bone.
was a big flat bone.
Yeah, so in essence though, it's important, and we start with just some basic anatomy so we can kind of make the point of what we're dealing with here.
Your boat analogy.
Yeah, so I'll go through that, I'll go through an analogy, but ultimately, the shoulder is ultimately a ball and socket joint. Hopefully this doesn't happen to you guys, but ultimately, it's a very, very shallow socket. So let me make sure that we're answering your questions, that the next part under B is the shoulder is a ball and socket joint. Okay, so again, very, very shallow socket. If you look at this illustration, the purpose of this shallow socket is to provide for a lot of movement. The other ball and socket joint in our body is the hip. We've got a fair amount of movement, rotation, and various movements, but not nearly as much, or hopefully not as much, because it's a deeper socket. And Michelle is a great illustration of the ball and socket joint.
For 20 years, I would do evaluations with shoulder patients, and I would always say, now look, there's not a lot of bony stability. We need your rotator cuff firing properly because you're like a baseball on a teacup saucer. Well, it took me 20 years later to start doing these workshops and actually bring my baseball and teacup. I still don't bring it into the new patient evaluations, but can you imagine how difficult it would be to hold this ball on this teacup saucer? The joint, you know, on the shoulder blade is the teacup saucer, very flat, shallow, and the baseball is the humeral head, and the rotator cuff is what holds that ball in place when you go to move. Very different than what Steve said. This is more like your hip socket. Okay, a little bit more bony surface there, and the ball sits nicely in there. Really difficult. You don't hear a lot of dislocated hips as much as you hear of dislocated shoulders. Now the trade-off is mobility, lots and lots of mobility, less in the hip, but the hip has way more stability just from a bony joint, ball and socket standpoint. That's a really important take-home message as Steve takes you through, you know, what happens when these rotator cuff tendons get off balance.
So before I move on to the surrounding parts of that, I'll give you guys a little analogy, if you will, and it's worked well for people to understand. Being in the South, and we typically like boats unless you've owned one and know that it's a hole in the water that we throw money in. I think that's what it's called, right? But ultimately, so if you've got, this is my poor illustration of a dock right here. So if you've got a boat, let me try to draw some semblance of a boat here. So if we've got a boat in the dock, so this is the dock, this is the boat. Think of the boat as the humeral head or the ball part of the socket. Think of this as the socket itself. Think of the rotator cuff as 4 ropes that hold that boat in the center of that dock. Okay, let's say it's a little breezy and there's some current. Okay, we know we get it, hopefully not this year, but we get a lot of storms, tropical storms around here and a lot of wind. So ultimately, what happens if we take that rope away? This boat,
Stability's gone.
that's exactly right. So suddenly, although these ropes are intact, the 3 of the 4, the boat is going to begin to drift relative to the wind, but also relative to where we have slack, where we lack stability. So suddenly this boat starts drifting and hitting this dock. Sooner or later, what's going to happen? One of 2 or 3 things. The boat's getting damaged, the dock's getting damaged, or both are getting damaged. We can even run into these other ropes and cause damage to those ropes, eventually cause really some major problems. So ultimately, I like to give you guys a visual illustration. I used that on a good friend of mine who actually needed rotator cuff surgery because he had some massive tears that there was beyond repair. But to see that illustration for him made the difference, really in understanding that what seems complex can be fairly simple if you just look at it in sort of a fundamental way. Any questions about that at all?
The thing I would add is usually we're not seeing a full thickness tear from a physical therapy standpoint. If we observe a full thickness tear and you are a surgical candidate, we can see that on our evaluation, and we're usually making recommendations to set you up to see an orthopedic just to look at, the do's and don'ts there. Normally what we see is slight slack in one of those ropes, and another one might be super tight. You might have one muscle that is tight, guarding and spasming, while another one is a little weak, and it just creates enough to get some butting up of that bone, and that's enough to create a little bit of inflammatory cascade, and that's when you start with things like tendonitis, bursitis. Those are your warning signs. Hey, something inflammatory is going on. Maybe your ropes are a little out of balance. Maybe your rotator cuff is a little out of balance. And there's other parts of the body that can play a role in that too.
So ultimately, to move on from an anatomy standpoint, the next question is, these 4 areas work together during shoulder movement. It's the neck, the collarbone, the shoulder blade, and the rib cage. So it's the neck, the collarbone, the shoulder blade, and the rib cage. And interestingly, one more time, the neck, the collarbone, the shoulder blade, and the rib cage. And interestingly, an interesting fact is the only bony articulation or the only bony attachment that we lost our collarbone. That's not good. So, we all know where our collarbone's at ultimately, but the only bony attachment that the shoulder blade or the shoulder complex has to the body is what's called the sternoclavicular joint. This right here. There's no bony attachment like you have one knee to the other knee and the hip but the only bony attachment that this whole complex works off of is right here. It's amazing to think of this shoulder blade basically as being the foundation from which the arm moves. That's the most fundamental piece of information that you can take away from this, is that the shoulder blade is the foundation from which the arm moves. That's really the key to our treatment approach, to figure out then is what's going on. To Michelle's point earlier, is it tightness? Is it weakness? And what is it from? If it's some weakness, why is it there? Why do I lack stability? What are some of the issues there?
And a little demo of, everybody can find their collarbone here. Put your fingers on it, and what this collarbone has to do to enable you to get your arm all the way overhead is it actually has to rotate like a log. It does a little kind of a log roll. So if you put your hand on it, put it on your better side or your good side, and as you raise your hand up, do you feel it roll back under your fingers? And you should. So as a physical therapist, we're not just looking at the rotator cuff, we're looking at that clavicle. Is it rotating properly here where it attaches to the sternum? What's happening out here at the shoulder on those two bony attachments? Many times just freeing up those, you can gain 10 degrees of overhead shoulder motion without getting pinging.
And it's also looking at the condition of the shoulder blade itself. How does it move
Right.
throughout movement?
So
Does
turn
it
around
move?
and I'll show them on you. So he said this was his right shoulder, and so we're looking at as the arm moves up, let's say into this sideward motion, there's actually a formula. This arm should move so much, and then the shoulder blade has to be able to move to help it get all the way overhead. If that doesn't happen, you're gonna get this bone butting up into that clavicle and starting impingement. We've heard that it might be a shoulder impingement. So what happens to him if he's working out in the gym and he's got these muscles so tight that this arm goes so far, this won't glide the way that it's supposed to, bam, bam, he starts hitting that. So as his therapist, I might get in there and have to do some soft tissue work to those muscles to free up some of that mobility.
And then also, like from a visual standpoint, a lot of people have pain right at the front of the shoulder. I think one of our Miss Linda's talked about having a spur, some osteophytes. Sometimes those osteophytes will take up some of the space at the front of the shoulder, and it's called subacromial space because the acromion is a bone at the front, so sub meaning under. So it's more important than ever with those osteophytes that we get the scapulas in the right position to give us subacromial space so you're not impinging. We'll talk more about impingement as something that you'll hear about again and again. So let's talk a little bit about some success stories, kind of have a method to our madness in the way we laid this program out. And one of the success stories, and I've never really used before, but it just came to me as we were talking before, Mr. Pat. And by the way, I would never say anybody's last names. It's just confidential and from a medical treatment standpoint. But Mr. Pat, who's a good friend of mine, fell against a fence and hurt his arm pretty bad. And it took about 2 visits for me to realize that I had to get on the phone, which we have good relationships with some of the docs that do some of the best treatments around. Dr. Savoy is one of them, and there's quite a few on this side that do a really good job. But I was able to get on the phone with one of the docs and say, hey, I need an appointment right now. There's something that I don't like that just doesn't smell right with his shoulder. Red flags is what we call them. Got him in an appointment that very next day and realized that he needed surgery. He had some full thickness tears. So I'll call it a success because I was able to save him a whole lot of time and headache of not getting therapy that I knew wasn't going to help him. And that's our obligation.
Wow.
And it's important because the last thing I want to do is drag things along only to realize. Now, there's some cases where docs will send patients to us to say, listen, in which we'll review, there's some problems that I see on imaging, but let's try the conservative approach first, knowing that they trust the work that we do, and then we can kind of determine in a very short period of time whether therapy is going to help them or not. So,
And I can share in a different way.
Yeah.
So that's our relationship, us, calling on the help of a doctor. Sometimes it might be, hey, this person is in so much pain and they haven't had an injection. Can we get them in, at least calm them down so we can do some stuff. On the opposite side of that coin, I felt very honored that I got a call from one of our local orthopedic surgeons who said, Michelle, I really need your help, which is unusual for them to call and say, I really need your help. And I said, okay, well, tell me more. He said, I have a friend of mine, she's a close friend, we were at dinner the other day, and she's had some breast cancer and some mastectomy surgeries and radiation and some stuff. She's all better, cancer was like 10 years ago, but she's had some revisions to her surgeries and whatnot, and she's having severe shoulder pain. This is like a 54-year-old woman who works out with a personal trainer. She's in great shape, she travels, she gardens, and she is miserable. And she is coming to me for injections that aren't helping. And she swears she needs surgery. Her imaging looks fine, Michelle. He said, I think it's some of the scar tissue from her surgery and her mastectomies and the radiation. And I said, okay. So he sent her over, and poor lady was having pretty radiating pain down through the rib cage, nerve pain into the arm, and really couldn't get past much of anything. I didn't start yanking and pulling on her shoulder, which was very tight, and she did need some help and some movement there, but I started through the breast tissue and in the rib cage and got her ribs mobile from some of the scarring that had happened, and within a matter of about 2 weeks, her pain was down by 50%, just from freeing up space in the rib cage and in the surrounding areas, and it at least gave her hope to know, okay, my shoulder is gonna be okay. She's been back to us a number of times and has sent some friends and family, and that was a day that I felt thankful that I could help that doctor out. So just sometimes an unusual thing, people aren't thinking scar tissue and ribs when it comes to rotator cuff treatment. So, 2 success stories of people that have come to us in the past, people we're thankful for, and hopefully make some success stories out of this room before it's done.
So, let's talk a little bit about imaging, x-rays, MRIs, and the such. Ultimately, there was some research that was done, research in terms of MRI and an x-ray and diagnostic imaging, 100 shoulder, pain-free people who, they wanted to do a study to figure out how many average people with no pain in different age groups have shoulder problems. Findings, MRI findings, and what they found after studying 100 x-rays on healthy people.
And MRIs.
I'm saying x-rays, but
X-ray and MRI
MRIs,
combination.
right. That they found that of 50-year-olds, 150-year-olds, what percentage of them would you think, so let me make sure I'll kind of chop my words up a little bit, I apologize for that. Of 150-year-olds with no pain that had MRIs on their shoulders, what percentage of that group do you think had findings of spurs, osteoarthritis, rotator cuff tears, and that such? What percentage would you think would be reasonable? Remember, people with no pain or problems.
100%.
In this case of 50-year-olds, which that's me, I still feel young here, 80% had no pain, 80%.
And so this was positive for osteoarthritis, degenerative joint, spurs.
Impingement, we talked about that impingement
Tears.
issue. That's the pain at the front of the shoulder. 60-year-olds, same study at 60-year-olds, 90%. 90%. And then 80-year-olds, 99%. So it's amazing to see, so we also see this relative to back problems and that sort of thing. We see a lot of MRIs and imaging. Very similar studies have been done with the lumbar spine or the spine in general. People with no pain that have positive MRI findings. So there's a common thread in what we do and what we see with this regard.
But my question is, how is that? So I just want to ask y'all, how is it that 150-year-olds, 80% of them have all of this and they have no pain? How is that possible?
Luck.
Luck.
Maybe
Some
magic
lucky.
wand, the magic wand that we talked about, right? You know,
The interesting thing is, these changes that they found, the osteoarthritis, the degenerative joints, the spurs, and the tears, largely a lot of that by the time you're 50 years old is normal age-related change that is anticipated in the body. Why do they not have pain? Well, chances are they've accommodated over time and they have enough mobility still in the neck, in the collar blade, the shoulder blade, and the rib cage, that they had enough free space that they were not getting that impingement on the rotator cuff tendons enough to create the inflammatory cascade. And I'm having...
and there's enough redundancy in the body typically that we've got room for error.
And to BJ said, I had an injection, but they don't seem to be working as well now
As they did originally.
as they did originally. Well, why is that? What is the injection doing? We're not here to say injections are all bad. Well, the injection is an anti-inflammatory. The inflammation is a chemical buildup in the body that occurs over time as things bang and do things. It's your warning sign. Like I said, the tendonitis, the bursitis.
Yeah, so you imagine that picture that I drew here, the boat banging against the dock. Something's gonna get, not in the case of a boat, but our bodies inflame as part of the healing process, believe it or not.
So the good news is about the medication, the ibuprofen or whatnot, calms down the inflammatory cascade. When that can't happen enough or fast enough, we move on to bigger drugs like the injection. And what that does is chemically goes in and snuffs that inflammatory chemical down to a tolerable level. Great. But did it get to the root cause of the problem, which was the lack of space, the impingement on the cuff tendons and the bursa and the articular cartilage? No. The cause, whether it was the clavicle that's not moving, the muscles that are too tight, the cause of the pinching that's causing the inflammation didn't go anywhere. So most good surgeons will say, take this medicine, I'm gonna give you this injection, and I want you to go see your PT. But unfortunately, most patients are like, well, gosh, that injection made me feel so good. Why do I want to go see a PT 3 times a week?
So we
right?
classify the injections as medications as a way to alter the pain, is how we're gonna classify that. So, like to Michelle's point, we're not getting to the root cause of the problem, we're altering the pain by snuffing out that inflammatory response or covering up some of the symptoms, treating the symptoms in that case,
And
right?
some of you in this room has even talked about altering the pain, altering it, even if not medications and injections. Well, I'll just use my left arm until it starts giving you trouble, or I'll just I won't reach it up so high, or I'll just stop fixing my hair like that. And so you might alter and have changed your movement patterns over time, and sometimes we have to fix that too when you come in, is change those movement strategies that you've learned over the period of time to get your movement patterns back to normal.
And I'll tell you, interestingly enough, from an experience standpoint and a clinical experience standpoint, is typically people who go into surgery, they have a set of problems that led to the tears and other issues, that led to the inflammation and some of these symptoms that we're talking about. So they'll go in for the surgery, but it didn't fix the original mechanical problem that caused it to begin with. So it's interesting, it's an interesting sort of quagmire in a way. So without the right care, and we'll go into a little bit about that, is what is the right care, what does the right approach look like? But ultimately, yes, absolutely.
Can you address how this would be effective if you've got bone on bone? And it sounds like a ratchet whenever you move your arm.
Yes, yeah, that's the arthritis part of it, and that's the deterioration ultimately of those joint surfaces. And in all honesty, strength, my best explanation is this: strength can typically overcome structural deficits. As we get older, our bodies wear down. We're surely not what we were when we were 19. Not even what we were when we were 30, let's face it, right? So ultimately, y'all be quiet in the back there. There's your 30-year-olds back there. But ultimately, our bodies are deteriorating over time. So we accommodate for structural deficits through strength. To answer your question specifically, is your shoulder in a condition that we can handle it from a therapeutic standpoint? Only an evaluation and assessment would let me know that. We treat a lot of shoulders that are arthritic, but ultimately what we need to do is give it the support it needs to keep it from, like that boat that's banging around against the docks. It can't afford to bang around against those docks anymore because you add inflammation to those rough articular surfaces. It's the cartilage. You know when you pull the end of the chicken leg apart and there's the slick surface? That slick end, that cartilage, the end of the chicken bone, is what we have on the ends of all of our bones, what we're supposed to have. And when it gets worn down is when it leads to knee replacements or even a shoulder replacement. But again, we've heard the stories. Now, if that's all that's left is to go get the shoulder replaced, I've got quite a few docs in my back pocket that I would say, definitely, I'll never tell you who not to see, but I'll definitely tell you who to see. I'll get myself in trouble that way. But because nothing other than we see the results, the successful results are the ones who do a great job. So to that point is strengthen the stabilization to keep those articular surfaces from banging around in each other like the boat and the docks. That's our best chance of getting your shoulder functionally feeling pretty good again. Will it get you feeling like a 19-year-old again? No way. I'm not here to tell you guys that at all. But we typically get them feeling a lot better. My own mother, for goodness
And
sake.
again, most of you are good surgeons. The typical treatment strategy, your good surgeons, even if you are a candidate for a replacement, are going to say, do PT first. It's conservative. See if you can correct those mechanics and get your strength balanced, and then it would be meds or injections and following that. If you're failing those things and it's still keeping you awake all night and different things like that, then you're a surgical candidate. And you can go into it knowing I've done everything I can.
And that's
This is my
exactly why
last.
I'm here. I'm trying to do everything. I've done
Yes.
everything.
And that's
Yeah.
I've done
very,
cryo,
very
I've
common.
done cupping, I've done massage, I've done lights, I've done.
Have you done physical therapy before?
I have done, not long-term.
Okay.
Yeah.
Okay, and fair enough.
And not where I think it was the better way.
Okay. Okay.
But interesting that you mentioned, because up until like a year ago, because I was just having someone, I would have little things with the shoulder, so I thought, I'm gonna stay ahead of this, I'm gonna get an x-ray, and at that time it's like, how in the world are you not having pain? And I wasn't, and I had full motion of this left arm, and then it started.
Yeah.
Yeah, it happens that way.
Yeah, so some interesting facts there. You want to move on to that chart there, kind of looking at some movement and that sort of thing?
Yep, all right. So one of the things that we're huge candidates of, huge proponents of is hands-on PT. And I'm still off of your handout a little bit. I want to do a little drill in the group. So if you guys would just put your stuff down on the floor somewhere close by. I want to see what the group of you guys look like from a movement perspective. And I'm looking for the right candidate. I'd like to do one little quick treatment with one of you, but I'm looking for the right person. So if you would agree to be my role model here, participate in this drill, because I want to look at what your motion looks like. I'm going to ask both of you, ask you to raise up both of your arms straight up overhead. And
With no pain, by the way.
see
I
how
mean, just
far they can-
whatever you can reasonably do.
I'm just going to kind of survey the room. All right. Okay, and you guys can put them down. Thank you. Next thing I would like for you to do is turn over your left shoulder. Look over your left shoulder as far as you can. Good. And over your right shoulder. Okay. All right. And you can rest there for a minute. Did you see a good candidate?
Yeah, I like the Miss Linda has some limitations, I think. Miss Linda, number two, has
In the
some-
blue
some
shirt, we were,
rotational-
this
yeah,
one?
Yeah,
In the
has some
striped shirt?
rotational limitations, but I know you had some other issues previous, so I want to be careful that we don't.
I didn't hear from you much in the back there with your white sweater on and your blue shirt. Tell me what's going on with your shoulder.
Oh, I'm in therapy now.
Yeah.
Oh, you are?
For my neck.
Oh, okay.
Shoulder issues connected with the neck. And
Yeah.
I'm doing much better.
Okay,
A
well,
lot of progress.
I saw that. I
Yes,
saw that
yes.
your right shoulder was pretty limited going up, and you were also pretty limited turning to that right side.
But you should have seen me when I first got here.
Yeah.
Okay, are you in therapy here?
Yeah.
Oh, well, then I don't know that that would be good. I'll be tooting my own horn.
Yeah.
Okay, well, come up here, if you don't mind. There is a,
Well, you didn't notice me, I didn't put my arms out.
I-
Right now, I'm suffering really bad right now. I didn't want to lift up one arm, but right now
Yes.
I'm in extreme pain right now.
yes, I did notice that, and I took it as you might not want to participate or it might not be the best candidate.
Yeah.
Come on up here. Even though I did not know she was our patient, because I work on the pelvic health side now primarily, that's my full-time job.
I was there
And,
first.
and so I only fill in on the orthopedic
It's a
side when I
great
need my
therapy
help, right? Well, thanks for volunteering. Before we start,
I think you will volunteer. But
I was not privy to this information. And you owe me nothing if this works, or hopefully we get some good results. So, actually, can I have you stand while I show them this movement? And you can put your glasses here if you want. All right, so show the group for me if you would, both arms straight up overhead. You guys can see what I saw. Oh, that looks better now. She's trying to show off. Okay, good, and down. And then turn your head to the left, and turn your head to the right. So did you guys all notice the right arm did not quite go as far? And I'm gonna add one more motion for you. Would you mind turning your back to them? And on the good side, right, that would be your left side, would you reach up for your bra strap with that, like behind your, let me show you, I'm sorry. Like this. Reach up and let me see how far that gets.
Go, girl, you got
You
it.
can at least do your bra with the left hand. Okay, without hurting anything, because your therapist will kill me, reach back and do that with your right hand.
Don't force it.
Yeah, okay, so if we were reaching for your back, so it's 2 inches from her bra strap, we can see that. So she's definitely got some shoulder range of motion limitations and some neck limitations. Okay. All right, so with your permission, it's the right side is the bad side. Okay, I'm gonna do just a little bit of hands-on work with you.
Okay.
What I'd like to do is press on your neck here for a minute.
Okay.
Is that tender there?
Just a little, not bad.
Too bad. Okay, so what I'm gonna do is ask you to move your head in a few different directions as I push and have you do some things, okay? So first thing I'm gonna do is have you push your head into my right hand here. Take a nice deep breath in and release. Now, tilt your head over to that left side. Okay, push into my hand again with your head, good. Hold it there, nice deep breath in. And exhale. You doing okay? Not hurting you? Can you take a slack, moving that head over to the left shoulder? Move, tilt it to the left. Good. Push gently into my hand with your head. Good. Nice inhale. And exhale. Are you doing okay? okay? Not aggravating your neck or
No,
anything?
it's okay.
Okay. A little bit further over that left ear to that left shoulder. Push up into my hand. Nice inhale.
Are y'all gonna fix us a list of masseuse people?
I'm sorry, okay.
Can do this?
Yeah.
Okay.
Yeah.
So,
Here,
3 to 5
up,
reps.
out.
Go ahead and stand up
Say
for me.
that.
Massage people.
Okay.
What about?
So let's
We
take a
need a
look.
list.
Oh,
And we want to just see if anything looks
Absolutely.
better,
Yeah.
okay?
You got
Or
one?
feels better. So guys,
Together for you.
what I'm looking for is did we get an improvement in shoulder or neck motion or a decrease in pain? So if you would, take both arms straight up overhead, just like we did in the beginning. Is it different? I can't tell.
It's a slightly different, yeah.
Slightly different. Okay, go ahead and let them down. Did you try harder that time just to make it look like it was?
I don't know.
Turn your head to the right.
Okay.
Any change there? Does it feel any different pain-wise?
It's a little bit more.
Look any different?
I think
Okay.
she had more ease.
Okay.
Turning it there.
All right.
Hesitation.
How's it feel in the motion of the neck?
Just a little crackly, but
All
it's.
right. You might have freed up a little motion. Okay.
Yeah.
Turn your back to these guys.
I did have neck surgery, that.
And then take your right arm and reach it up where your shoulder blade, if you would. And there's her bob. That's about 2 inches. Slight improvement. Thank you.
All right.
And I promise if you're flared up tomorrow, I'll take it back with your therapist.
So ultimately, I'll tell you all this, is that typically the results are relative to the length of time, and this is true for physical therapy in treatment. The response is usually relative to the length of the time the problem's been around. If it's something that you just sort of tripped and twisted an ankle, usually we can help that pretty quickly. But if you've been dealing with a neck and shoulder and this combination of things, this cascade of problems, or this onion of problems that you've stacked one accommodation on top of the other, sometimes things can be a little bit more difficult, and you don't see sometimes there's so much of an immediate response. But you do, whether it's here or wherever you're at from a medical care standpoint, is the response that you ought to see should be measurable and it should be soon. That's something to remember. It should be measurable and it should be soon. If not, your therapist ought to be able to look you in the eyes, or a chiropractor, wherever it may be, look you in the eyes and say, this is where we're at and this is where we're going, just as a side note.
And I would say this, I started to disqualify you knowing you were in treatment. I assumed somewhere else, I didn't want to mess, but then you had neck surgery. But you had the right movement patterns. And my takeaway, if you were my patient, was to say, okay, we maybe only got 2 or 3 degrees for your shoulder and your neck, but in two different ranges of motion. But if we added that up over a period of time, you're only lacking 20 degrees, we should be able to see measurable gains in a matter of a month's time, you know?
And like we've been seeing with, like you said, with the neck.
Yeah, lots of gains,
Good.
because I had it really limited when I first got here.
Well, thanks for
Yeah.
participating.
Yeah.
I have a question, so what about maintenance? I mean, like, you get it right and you get more mobility and.
Well, that's where the fine-tuned
Yeah.
one-on-one exercises come into
Yeah,
play.
we'll talk a little bit about that, but ultimately, let's talk a little bit about, I'll explain a little bit about me and why I do this. I was intrigued. I've spent a lot of time in the gym over the years, exercising and trying to stay fit. And what I realized is there was a lot of people that continued, that was very muscular, that was in very good shape, but continued to have shoulder problems. A lot of the guys in the gym, they walk around after they bench press, and a lot of guys and girls the same, sorry. I say guys, but mean that interchangeably, that, they walk around grabbing their shoulders after they maybe shoulder press or do bench press or some of these other things. And I was really intrigued by the fact, early on out of school, thinking, how can a person that's so muscular, because I talked before about muscles overcoming the structural deficits, right? When the structures wear down. And I'm thinking, here's a young person with a lot of muscle, how can they possibly have pain? And I wanted to better understand that. So ultimately, what I would be, that led me to my quest for knowledge of what's causing it and how do you fix it. And multiple courses, training, working under very good people, you realize what works. You realize that you could really make a positive effect. And the other thing for me is that shoulders, for me, was one of the most complicated joints in the body because there's so many components to it. And I felt that it was my weakest area out of school. I wanted to get better. I wanted to know more. I wanted to be able to help these people that were walking around with pain. And then I realized there's a room full of people like you guys, day in and day out, that don't have the answers they're looking for. They want to avoid surgery. They don't want to have to take pain medicine. How do I fix this thing reasonably? that's what led me down the path that I'm at right now.
And I became the expert in shoulders because who do you think was his therapist when he would injure himself in the gym? So I had to get good at it.
So back then, I've been out of school for quite a while now, and I looked at across the board at the success people were having, and ultimately, 20 years ago, when you look at the success that therapists were having with patients, ultimately, only 25% of people that went to therapy got better. Okay? 25% of them were no better, or just no change. And then 50%,
They were better, but to your point, they
Yeah.
couldn't maintain.
yeah.
They had improvement, but they weren't maintaining.
And
Life happens.
Yeah, and that's the key, because I hear a lot of people say, well, I've been to therapy somewhere else. And it just, it felt a little better, like trying those few exercises that you all talking about earlier. Try a few exercises and maybe it made it a little worse or that sort of thing. And it intrigued me. I said, well, what? Where's the problem? And what we realized is that now, when you look at statistics now, that with hands-on physical therapy, there's very, very different approach to care now. And when you go to the right clinic who performs hands-on physical therapy, hands-on care, 90% of people with these MRI findings that we talked about before and all this, the situation hasn't changed, but 90% of people that seek hands-on care get better.
And it's just like that little technique that we did, but how many times have we had patients come in that they say, oh yeah, I did physical therapy, but it just, it helped for a little while, but it didn't really get me where I need to be or whatnot. Two things have happened, and then we go to do some stretching and mobilization with them, and they're like, wow, they never did that at the other place. And guys, we've been PTs for 25 years, and I'm associated with LSU, their PT program. I sit on their advisory board. I know what they're teaching these students, and it's hands-on physical therapy. Where they're getting it out of school now. The problem is some facilities are booked a little too packed, or the therapist doesn't really have the interest or the time to take the time and do the hands-on piece. And it's a little bit unfortunate because we're all trained in the same way and we all share the same passion for getting people better, but it does take the interest and the time and the willingness to put your hands on somebody and do that soft tissue work to the shoulder blade or to get that collarbone moving a little better. And what we did was just a first rib mobilization. And your first rib actually lives up here, and the neck, since she had the neck limitation and the rotator, the shoulder limitation, all I did was free up some mobility in that first rib so that the nerves and the muscles that traverse that area could free up a little bit. But if you found yourself in PT before, where we hear it all the time, it's just, oh, here, do these exercises, just go do this on your own, or somebody to follow you around. The maintenance part is we free some things up, but we give you the exercises to keep that motion in or to strengthen up that new range of motion that we just got. So it's a hands-on
Yeah.
stuff that makes sense.
And something that's very important, it could be the right exercise done the wrong way or done in the wrong order. It's like doing combination. So if you have, let's say, a combination lock with 5 numbers, well, if you either get them out of order or you don't have the last number, you've got everything in place except they're not in the wrong order or they're just the wrong number. So you're this close, but it's not quite there. And oftentimes, if little things are missed, like maybe the shoulder blade isn't working well. So I'll have people that come to me as a second opinion, and their cuff is really strong, but the shoulder blade's winging. It's the foundation, the scapula, is winging. It's not staying where it needs to be. It leads to an impingement. So of course, things are gonna go very downhill very quickly. It's like tying that boat off to a piling that's sort of rotted out and it's not doing its job. If it's not gonna provide the stability, the boat's gonna have issues. The good news is we talked about a list of conditions or positions, whether it's reaching for your bra, reaching to the back seat, sleeping. How many people have trouble sleeping on their shoulders? Some of them won't even try, right, because it hurts so bad. The good news is that we like to say if your shoulder pain is reproducible, and that's one of the questions on number 3, is that if your shoulder pain is reproducible, then it's reducible. think that's really good news for a lot of us.
Yeah.
If it's reproducible, it's reducible.
I'm gonna sneak in a helpful hint after you guys write that down. Because I promised you guys, that position of sleeping, right? So when you come in, I'm gonna show you. How many of you in here have difficulty sleeping because of your shoulder pain?
Yeah.
Probably at least 50% of you, if not 80% of you. So patients try to sleep on that shoulder and it wakes you up at night, or trying to put it overhead isn't gonna work. Where do you put it? The best place, the best way to sleep, this is not a great example of a pillow, but imagine this is just a regular pillow you would use under your neck. You're gonna take the middle of that pillow and shove it right up into your armpit, okay? When you do that, you've opened up the ball and socket into an open pack position. You want about 30 degrees of your elbow away from your body. That open pack position is the maximal position for blood flow, oxygen and nutrients to get in there. Your body is largely healing overnight. Throughout the night is when our healing process takes place. If you ever see people with their slings and they have that big bolster after surgery, they're trying to keep them in that open packed position for blood flow, okay? It's the best way to reduce inflammation. So if you're on your side, your good side or your better side, this is how you want the pillow for sleeping on your side. If you're on your back, you would want the pillow to also support your elbow so that it doesn't fall.
So you notice
backwards.
once our shoulder goes back, and different body designs are different when they lie on their back. Some people, when they put their elbow here, it forces the shoulder forward. We keep talking about impingement. Well, you've
Or
got the
that
bony
biceps
area here, As this goes forward, it shoves the humerus forward into the acromion and impinges those tissues up under here. And that's very, very painful. So to avoid that is we prop the pillow up under.
So on my
So
back.
she's laying on her back, we prop that pillow under her elbow to keep that arm from going back and dropping the shoulder forward. So there's little tricks and things
Even
that
if
we
you're
can
sitting on the couch, so you're seamstressing or whatnot, and you're taking a break, put the pillow under your arm. You're gonna be shocked. Or driving, having your arms slightly supported out on the armrest. I just wanted to share that with you guys because after the last workshop, I did one of the free exams the following day or week or however it went. And he was like, do you know what? You were right. And I couldn't have staged it better. The only reason he was here was to come with a friend. He said, I had shoulder problems, but it's all better. The only thing, I just can't sleep at night. So I said, well, let me show you this. He said, I don't know why. That's magic. It worked. I'm like, well, okay. Then why are you here? Do you need my help? So give it a try. Hopefully, at least you guys can have a better night's sleep as a result of coming today.
So under B3B on your sheet, in the past 30 days, the worst pain I've had is X. If you guys would just fill that in, the worst pain in the last 30 days.
Looking for a number?
Looking for a number, scale of 0 to 10, 0's no pain, 10's worst imaginable.
And it just,
I understand.
Yes.
But it's intermittent, it's not constant.
Well, what they asked there is the kind of what's the worst pain is what they want to know over the last 30 days. So I would just jot that number down. And then there below it says, I have pain when, and then circle all that apply. Lifting, carrying objects, reaching overhead, reaching behind my back, getting dressed, sleeping. And if you have anything to add, you feel free to add a few little things there. But ultimately what we realize is that the biggest mistake shoulder pain sufferers can do is ignore it. There's a variety of actions that we can take. We talked before about we can do things to alter it, whether medication, injections, and sometimes as we discuss, injections are important. Injections are a vital part of treatment. Sometimes we'll recommend, we'll get on the phone with the doc, hey, is an injection appropriate at this time so we can get the irritation down, inflammation down, so the patient can tolerate treatment. But it's only after being educated properly to know that, hey, you're gonna feel a little better after the injection, but if you don't take care of the mechanical problem, the pain's coming right back.
So you guys all got number 4, the biggest mistake they can make is ignore it. And then number 5, 3 things you can do about it. He said alter it, he said ignore it, or handle it. And now by that, you mean get to the underlying cause
Okay, 3 things you can do is alter it, ignore it,
and handle it.
ignore.
Alter it,
Ignore it.
ignore it,
Oh,
or
right.
handle it.
Yeah.
You can continue to ignore it, it's not going away. Usually it'll get worse. You can alter it with medications or how you move and do your life differently until it gets ahead of you. Or you can handle it, and that usually means figuring out what is the underlying cause and fixing that. So, 3 top causes of shoulder pain. Number 6 are problems in the neck. We alluded to that. What we didn't talk about in the neck is sometimes you can have those pinched nerves from a disc. The nerves that come out of the neck largely innervate the rotator cuff. So sometimes patients will come in and they think it's weakness from the rotator cuff, but we're also trained in how to evaluate the neck to make sure that the neurological system is intact and that it's not something coming from your neck that might be contributing to that rotator cuff. So
And that also would affect everything downhill, elbow,
it
wrist.
can,
Potentially.
it totally can. And so you're gonna want, and that's a lot of times the orthopedic surgeon will say, look, why don't you go to the PT? Because they know we're gonna do a thorough musculoskeletal evaluation starting at your neck and working all the way down to your pinky if we have to figure out what are those underlying causes.
And so, in part of that, the problem is we could go on and on with different stories. And again, we agree that this was an hour setting. But ultimately, there's a lady that I'm treating right now that was sent to me with neck problems. And one of her biggest issues, because of the neck problem, she's got major shoulder blade weakness because of the innervation part. The nerves aren't communicating well with the muscles in the back. So for me to get a reading on that quickly, start working on that as we're working on the other structural problem. So it's the ability to be able to look at the body as a whole and not just to say, oh, here you are, you're a neck problem, let's just work on the neck. You know, things have to evolve to say, as a result of the neck, now it's appropriate to start moving on to other body parts.
And that kind of ties into the diagnostic imaging. Sometimes you have this kind of blinders on with the imaging because they're only looking at the shoulder. They didn't take a look at what was going on in the neck or vice versa. And so a musculoskeletal expert like a PT to evaluate those different parts can be very helpful. So going back to number 6, we said problem in the neck. B is impingement, which we've talked a lot about, how taking up space and pinching off the structures. And C is poor posture. And so we usually do a little demo at this point, which is, you guys already moved your shoulders up for me. What about in your worst posture here? How does it feel or look when you're slumped over? And think about that, because you've taken away some of your mobility of the shoulder blade and some of the different parts that need to move. So in your exercises now, we've told you we were going to give you the top 3 exercises, and we did. These are the ones in the research that are studied. My question for you now is, are these the top 3 for you and your individual problem? Well, that I don't know because I haven't done an evaluation. I don't know. But one of these first ones is a postural correction exercise to help get that shoulder blade in the right position. Number 7, what does successful, non-invasive, natural treatment look like? It's A, hands-on PT. The next blank is to move the shoulder and surrounding joints. B is strengthening exercises to retrain muscle memory. Get you guys out of those bad habits that you have evolved by altering your movements over time. And sometimes it requires a therapist sitting there and telling you to turn this muscle off. No, don't do it like this, do it like this, okay? And sometimes we have to help with that. So did everybody get the blanks filled in for 7A and B?
Yep.
And C?
And treatment looks very individualized, you know, to that point, as you guys are maybe finishing that, writing that part down. Treatment looks very individualized. A lot of people want to know, what's my recipe? I'd like to walk out of here with my exact recipe. And one of the things I can tell you, quite honestly, with that list of exercises is simply this. Our philosophy here, and yours should be, it's never no pain, no gain. Never no pain, no gain.
Just the old way.
That's right. If you're exercising and it hurts, you're doing it wrong. If I'm your therapist and I'm telling you to exercise like this and it hurts, we're doing it wrong. You should feel better as a result of care immediately, not worse. Always. You may feel fatigued. We may put ice on it at the end to calm the inflammatory process down, but I want to leave you with that little pearl, and it's one of our secrets. One of the things you learn first thing here. First thing I tell you, introduce my name and say, this should never hurt. So I felt like just an important point that I wanted to bring up.
Thanks. The last thing, C, is pain and inflammation relieving modalities. And Steve kind of touched on that a little bit. It might be the joint mobilization, the soft tissue mobilization, or things like ice and stim. Sure, pain and inflammation relieving modalities. And we invested in a class for a laser here that just changes the blood flow and the nerve synapsing between the nerve and muscle. I had a patient after one of these workshops that came in, and I went through the evaluation and told him some of the underlying causes and set out what the treatment plan would look like, and he said, wait, you can't just do some and like get it back? And I'm like, how long did you say this was going on? Oh yeah, like 10 years? I'm like, nope, I don't have that, you know, fairy dust is out. And, but we didn't have the laser at the time. Had I had the laser, it's not fairy dust, okay? But I could have gotten him a pain relieving response that day, and he was really just, he didn't want to take medicines, he didn't want injections, but I could have run the laser over him and at least had his pain reduced by 50% so that we could free up some range of motion so he could get the exercises done. And we do see that work for a good number of people.
Oh, I wanted to give you all this fun fact too. I thought this was interesting. I promised you all this great story with Ryan and I. So the pretty good therapist that I am, right, I feel like I can hold my own and treat some shoulders and have some fantastic results. So I was trying to treat myself after I injured myself. And I worked at it, just couldn't get it better. And I've been doing this a long time. I can get shoulders to sing to us. So I see Ryan at the gym and I say, man, my shoulder keeps bothering me. And I had him take a look at me. He says, well, why are you doing that? I said, well, I'm trying to keep my form. He said, you're not even close. I tell you how stubborn I was. I made him get his phone out and video me because he told me, Steve, your form's terrible. I couldn't see myself. I'm just using the weights and doing my thing. I said, no way, man, you just aggravate me. He pulled his phone and videoed. Until I saw that video, I wouldn't believe a guy that I've got more trust in than y'all can imagine. I had to see that video, right? I mean, Ryan, do you remember that
That's
day?
why I fired him as
So-
patient.
Yeah. So ultimately, even with the experience that I have, I can't come close to treating my own shoulder. And so,
So I'm excited that you guys came out. We are at about the 1 hour mark, so I appreciate it. And we, the 4 of us, are gonna stick around and answer your one-on-one questions. But I would hope that we, either Steve and I or the other shoulder experts that we have here, the physical therapists that have worked closely with us, trained with us, mentored with us, that we trust immensely, would get a chance to see each one of you and help you along your journey to get your shoulder better at some point. So you have 3 choices, right, of what you can do from this point on. Hopefully we've given you some education, some strategies, giving you some things to think about. Hey, what does my case look like? So the 3 things you can do. How many of you in here, after getting this information, are gonna go ahead and continue to ignore it? Show of hands, how many? Good answer. Thank you. It only gets worse over time, unfortunately. How many of you are gonna continue to alter it? I'll just change my position, I'm gonna go get that next injection, I'll just keep taking the meds. You're gonna do that? Okay. I'll write your name down for about 6 months. Oh, one thing we didn't say about the injections is it actually does wear down the tendons, makes them a little bit more frail, and so just doing the injections alone can create some problems. How many of you are ready to deal with it and actually handle it and ready to get to the underlying cause? Good. We've given you enough information to think about that there's it's definitely worth going through the conservative
I have
measures.
a question. Do you recommend coming in for an evaluation before seeing a doctor or see the doctor first?
Either way, so we are a direct access state of Louisiana, meaning you can come off the street to see us for an evaluation at any time.
That was a good question.
Insurance.
Get a prescription from a
Insurance, if
neurologist.
you are a government mandated insurance, and those insurance ladies can answer all those questions, but they'll let you know if you need a doctor's order. But we can always see you for a free exam, write a little nice happy note to the doctor and say, hey, this is so-and-so I met, sending her over with XYZ. She is an appropriate candidate for physical therapy. Here's my script. If you agree, please send her back. We'd be happy to help. So we help facilitate that process for you guys.
and even make
it easy.
recommendations on doctors. We try to be fair. We also offer a couple different recommendations. There's no favorites, no special deals with anybody. We don't work like that. It's just simply best practices, the best results. So if you need advice on that, we can also offer some advice on who would be the best one for your particular problem.
From here, what I'd like to do is have you guys hold on to your worksheets, because that's good information that you took the time to write down. Don't leave it for us, I already know the answers. You do have the feedback form. If you could give us some positive feedback on how we could make this better for future workshops, we're always happy to have constructive help, something that could go better, or maybe something you really enjoyed. There's some contact information. We're lucky enough to have Candace and Sherry, you guys met them when you walked in, and Mandy and Leanne from our West Bank and Sidell Clinic. They're gonna hang out and work on finding spots. We are pretty busy in summertime, but we knew we were having a workshop, so we held a few spots for free exams, held a few spots for evals, and we'd love to see you guys get into you want to.
So I think we're gonna just stay back here?
Yeah.
You wanna send us the few?
Yeah, if anybody wants,
And
if
us
anybody really
therapists will
wants.
be here to answer your questions.
Yeah, if anybody really wants a schedule, we've got a few really appointments that we set as soon as, they'll let y'all know, but, ultimately, if you wanna set something with them, and like Michelle said, we're here to answer any questions at all. And I challenge you guys, I wanna know personally, if I'm not the one that treats you, we've got Scott and Don, some great therapists here as well, Kristen, who we work really closely together, but I'd like to know, once you're evaluated, what's your problem? Is it tightness? Is it weakness? Is it the shoulder blade? Is it the cuff? Out of curiosity, you guys have been through this journey so far, but I'd like to personally know, what's your holdup? Is it the shoulder blade not functioning properly? Is there some issues possibly with the neck that we need to work on?
And so when you come in, even if it's a free exam, which is just a shorter meet and greet type of visit without doing insurance and orders and all that, we're gonna look at you, ask some questions, and try to offer some solutions of what might be the underlying cause. To truly really measure everything and figure it out for an underlying cause would be an initial eval. But you should walk away from that first visit knowing, hey, what's my underlying cause? What's my specific treatment gonna look like? What's 1 or 2 things I can go home with today that are gonna start helping me? And what does it look like in the long term? Again, if it's been going on for 10 years, you might be signing up for a month, 2 or 3 times a week with some things to do at home. But I'd love to get your feedback sheets, and maybe those of you guys that started off with the higher levels of pain up in the 7, 8s, 9, if you know you're ready to get started, head on up to these ladies, and they'll fit you in some of those spots. For the rest of you, hang out with us until they free up, and we'll answer your questions.
And who was the insurance lady?
Candace and Sherry, all these guys,
Yeah.
they'll get y'all squared away. And if not, like you said, if not, we're glad to answer any questions here in the future. And if you guys aren't ready to commit at this time, no pressure at all, we're glad to have y'all. Thank y'all for coming.
I have a question.
Yes, ma'am.
What about nutritional support? This collagen work, a lot of people are raving
Thanks for coming.
about collagen.
And I'll be honest with you, I've read some different reviews. I can't say for certain. Scientific research. Quality, I'm sure, is going to be important to make sure that it's the right supplement.
And they say don't do type 2, type 1, and type 3, you'll cause problems. And do it type 1, which is type 3. I mean, you get embroiled in
When you start reading threads on it, everyone's the expert, and that's why from a professional standpoint, I'll tell you, I don't know enough about it to really give you some guidance. And the problem is, so who do you look for? The doctors oftentimes don't. If it's not prescribed, no offense to those guys, but oftentimes they don't hear about it. I'll tell you, I don't really know a good resource to say, look at this, how do you really figure out?
I feel safe with WebMD, Mayo Clinic. You know, I'm feeling kind of safe. I don't think they're going to recommend a particular brand.
Well, what you can look at is the research, look at the outcomes, the research. And I think that will be your guide as you read the abstract articles, what seems to work, what's right. They'll even sometimes list by name the quality of the product.
Well, I had a brand recommended to me. And my joints, I need to I mean, like a lot of things. But breast cancer surgery, I had a double mastectomy, I'm still having those issues. When y'all were talking about that, one particular thing was scar tissue causing the problem. And I would love to find somebody who does massage who's knowledgeable about my body.
This is relative to the shoulders and function to your feet, scar tissue, surgery, plastic results from breast cancer treatment, that sort of thing. So we're experts in tissue, so ultimately some of that tissue mobility
Your pecs are tight.
Well, but, you know, every time I need to massage, what was it called? I get a point, I've done that.
sleep too, so that I didn't break my arm.
And I wanted to get off as soon as I could, so then I went and college at the Hamilton Knights. And for the last 2 weeks or so, I've been kind of and that's why I really thought maybe it was this problem.
Speaking in general terms, like, you know, look at it like this. How do you think, ultimately, do you think your neck pain came first? Or this is right. What did you notice first? What did you say?
Because in November, the bottom of my shoulder blade, and I went to a chiropractor, and and push and move your hand while he's pushing. So, and then it kind of went away, so I stopped going, and I said, okay, at years, or it could kill me, I could, came up again.
So I'll tell you like this, I drew the diagram of the humerus in the shallow socket, the boat in between the dots. Also the blade, the way it sits on the thorax, the way it sits back here, there's also, I'll really oversimplify it. It's got to be balanced in the way that it's tied down. Because remember, like I said, the only bony attachment is right here. So it floats on the blade. That it's muscles. So what happens is that when some aren't working properly, it could be, the origin could be from original neck problem, that the nerves aren't communicating properly. Or it could be that there's some other issue, some other thing that happened to the shoulder. Now it started compensating. We're doing a lot of this. So one thing will irritate the other because the neck and the shoulder girdle is intimately intertwined. So what happens is as you start lifting, so it's first to get to the root of the problem. What's going on with the shoulder? I feel it. Just feeling it. I feel the humerus. Humerus head sits anterior, sits forward in the side. I can just touch it and feel that straight away. I can feel the gap back here, and I can feel this gap. Well, or it's a symptom. Let's just say it's a symptom. And when the tongue is able to hold this humerus back, so if I take and give you a little bit of pressure in the humerus, I can relocate it and push it right back to the center of the side. And when I do that, it should start feeling better. Now, it might hurt a little bit where I'm pushing on the biceps, but as I hold it back, it should actually start feeling a little better. One of the other things that